So I'm going to talk about, I'm going to follow up from those two excellent talks about phase 3 and phase 2 trials that you've already heard. And I'm going to talk about how you appraise a phase 1 clinical trial. The example that I'm going to give is this publication from the New England Journal 2 years ago, which was the phase 1 publication of this KRAS G12C inhibitor called Sotorasib. And this is a phase 1 trial done in advanced solid tumors. So you might think, well, you know, this publication in the New England Journal surely should be a kind of gold standard, and every point that we would expect within a phase 1 clinical trial publication should be included in this. Hopefully I can show you that whilst no doubt this is a kind of groundbreaking and practice-changing publication, there are things in terms of how this has been reported and so on that ideally when we discuss and think about a phase 1 trial, there are perhaps some flaws and inconsistencies. And just to say, I think, again, my co-speakers have touched on this, when you're looking at a trial, always start with looking at who is the sponsor of the trials. In this case, it's a pharmaceutical company, it's Amgen, who's the maker of the drug. And also look who wrote this editorial, wrote this publication, because that's also important in terms of how perhaps certain biases, either consciously or subconsciously, might come through. So this actually was written by initially by a writer employed by Amgen, and then obviously the investigators and co-authors then obviously provided further input and guidance on the manuscript. So again, just important for you to be aware of that. But let's take it back to first principles. So I'm aware that for many of you, phase 1 trials are things that you may not have seen or be aware of. So I'll just take it back to first principles. So first of all, what is the goal of a phase 1 trial? So the goal of a phase 1 trial is to accurately determine the safe dose and schedule for a new drug treatment. So it's really all about safety. However, it should provide the basis for later investigations of efficacy and superiority, what we've heard about in terms of the phase 2 and phase 3 clinical trials. And it really provides the first opportunity to test an experimental agent or combination of agents in humans. So there are different types of phase 1 trials. So again, that's the first thing you need to understand. It can be the first evaluation of a new cancer therapy as a single agent. So what we call first in human, first in class, which is the first compound ever evaluated in humans against a new molecular target. So that this particular study kind of fulfills that brief. Others might be a first in human, but not first in class. Other agents of the same class have entered human testing. And then we have a whole range of combination phase 1 trials. So these might be combinations of investigational agents, or an investigational agent with an approved therapy, such as chemo. You might have a new combination of approved agents that needs to go through phase 1 testing. Approved agent or investigational agent with radiotherapy. And then you might have a specific combination where you're testing some pharmacokinetic or pharmacodynamic focus, such as food effects or new drug formulations. So when we come to think about drug development, we kind of need a conceptual framework around which we assess a drug, and we assess how suitable it is for further testing and a further evaluation. So this framework, called the pharmacological audit trial, I think very nicely helps us to put these types of studies, such as the Sotorasib Phase I, into a kind of context. And so whenever you're reviewing a phase 1 trial, think about this kind of audit trail. So this was actually conceived by my previous mentor and supervisor, Professor Paul Workman at the Institute of Cancer Research. So in essence, it goes through a number of different things that we need to consider, and these are listed here. So first of all, defining a target population. So that would be, for example, for a molecularly targeted drug such as Sotorasib, the actual cohort of molecularly defined patients, okay? Often that might not be so clear to be able to test it in that way, but in this particular study it is. Then you look at pharmacokinetics, pharmacodynamics, biomarkers of response, perhaps some early predictors of response or resistance. And ideally, especially for molecularly targeted agents, we need to understand what the mechanisms of resistance are and how those mechanisms might allow kind of a rational combination of drugs to overcome that particular resistance. Okay, so have this kind of audit trail in your mind. And actually, you can put this audit trail into a number of points within the drug development cycle. Okay, so for us doing phase I clinical trials, we have to start by looking at preclinical development. And so from a preclinical perspective, you know, and all of these kind of red marks here, these red lines kind of are points where there should be a kind of go, no-go decision about whether the drug should be taken further forward and evaluated, or whether developments should stop. So from a preclinical perspective, okay, we need to demonstrate preclinical xenograft growth delay. We need to see, we need to understand the preclinical pharmacokinetic pharmacodynamic relationship. In particular, we need to understand the preclinical dosing which is required to cause growth delay and to understand the pharmacokinetics related to that. And we need to understand, obviously, the population likely to respond. So from a phase I drug development perspective, we need to identify a dose and schedule where we've achieved the pharmacokinetic targets, where we've demonstrated proof of mechanism pharmacodynamic biomarkers within the tumor, and we need to have been able to test assays to define that patient population if that's not clear up front. And sometimes we need to think, depending on the drug, we might need to be able to think about things like food effects and drug interactions. Okay, so this is just an important kind of concept when you're thinking about phase I drugs, how to kind of assess them and think whether they are suitable for further evaluation and testing. So what is the background to this? So Sotorasib is basically a drug which targets KRAS G12C mutations. So KRAS, you'll probably be aware, is the most frequently mutated oncogene in human solid cancers. And historically, it's been regarded as being undruggable. And that's because of from a medicinal chemistry perspective, the lack of accessible binding pockets, and when KRAS is in its active state, it has high affinity for GTP. So KRAS G12C mutations occur in approximately 13% of non-small cell lung cancers and in a smaller percentage of colorectal cancers and other solid malignancies. So Sotorasib is one of this kind of new generation of kinase inhibitors, which is an irreversible small molecule inhibitor of KRAS G12C. So it traps the oncoprotein in its inactive state by blocking the reactivation through nucleotide exchange, and it's through a unique interaction with what's called the P2 pocket. So it's really a kind of triumph of medicinal chemistry, because, you know, we've been trying to drug KRAS for many years with very little success. So again, thinking taking a bit of a step back and thinking, what type of patients should we include within phase I trials? So historically, for a lot of phase I trials for anti-cancer drugs, we've only used patients who have progressed through all conventional treatment options for their cancer and have no standard treatments left. Now we are actually a little bit more flexible, and often, whilst we are still evaluating the majority of these drugs in an advanced disease setting, that leaving patients to a point where they don't have any standard options left and often are very heavily pretreated has now reduced, and we're introducing phase I trials now. It's often at a much earlier point. But they must still have an adequate baseline level of fitness, so usually good performance status, 0 or 1. Obviously, I note Dr. Kumar Prabhash's comments about what is the general applicability of having such tightly defined populations to our broader patient populations, and so we must always bear that in mind. They must have adequate hematological, biochemical, and organ function, and usually have a life expectancy of at least 12 weeks. You need to have evidence of measurable or evaluable disease, resolution of all toxic effects of prior treatment, and usually there needs to be a washout period from your last dose of anti-cancer therapy, depending on the class of drug and the type of drug it is. That can be anywhere between 2 to 4 weeks. And as within any clinical trial, the patient must be able to provide written informed consent, and the patient and their families must be able to be given time to be able to understand and assess the potential benefits and risks of an experimental therapy within a phase 1 trial. And they must be able to comply, obviously, with scheduled visits, the treatment plan, and the trial tests. Exclusion criteria, these are the kind of commonest ones. You can't have another anti-cancer or investigational therapy, obviously, alongside any phase 1 clinical trial. Brain metastases, again, is usually again, historically has been an absolute contraindication. Nowadays, patients with brain metastases can often be considered for phase 1 trials, provided that they have previously been treated, that there isn't any ongoing neurological consequence, and they're off, for example, steroid therapy. Pregnant or breastfeeding women and males and females who must be able to use effective contraception. So again, pregnant and breastfeeding women, unfortunately, is an absolute contraindication. And this last bullet point here really is about patients who have another ongoing concurrent severe and controlled medical disorder, such as heart failure. These, again, are usually excluded. So what about the Sotorasib phase 1 trial? So it broadly kind of matched what I've just said. So age greater than 18, patients had to have a confirmed diagnosis of a KRAS G12C mutation. And that had to be done, that could be done through local molecular testing, had to be done on tissue rather than on circulating DNA. Patient's performance status was 0 to 2. So again, a slightly more flexible than many phase 1 trials that we do. They needed to have measurable disease. And for patients with non-small cell lung cancer and for patients with colorectal cancer, there was a slight difference in terms of the kind of prior lines of therapy. So for patients with non-small cell lung cancer, they had to have previous platinum-based combination therapy or a targeted therapy or both. And for patients with colorectal cancer, that they had to have had at least 2 previous lines of systemic therapy for metastatic disease. So again, these patients probably slightly earlier than perhaps many patients in the context of phase 1 clinical trials, but again, given what we've discussed, probably reasonably heavily pre-treated. And then in terms of key exclusion criteria, untreated active brain metastases, and this particular trial had a washout period of 28 days before from previous anti-cancer therapy. So next question for phase 1 trials is, how do you escalate the dose? So what is the design of a trial to be able to escalate a dose? So there are a number of kind of principles when we think about this. So the first is you have to start with a safe dose, okay? You should try and minimize the number of patients treated at subtoxic and perhaps therefore subtherapeutic doses. When you don't see any toxicity, you should escalate pretty rapidly. But as you start to see toxicity, perhaps you should slow down. So these are historic principles that we've done, that we've based many phase 1 studies for. And another kind of assumption that we've historically had is the higher the dose, the greater the likelihood of efficacy. So we use dose-related acute toxicity as almost as a kind of surrogate for efficacy. The highest safe dose is the dose most likely to be efficacious. And dose effect assumption is both for for cytotoxic agents. However, perhaps there are slight differences between cytotoxics and, for example, molecularly targeted therapies. However, for both molecular and cytotoxic therapies, higher doses of drugs are likely to be associated with less resistance. So this is really about how you try and push the dose, but not only because we assume dose, the higher the dose, the higher the chance of efficacy, but it's also about trying to reduce the impact of resistance, certainly for molecular and cytotoxic therapy. Immunotherapies are different, and I'm not going to cover that here today, but immunotherapy has different principles when it comes to phase 1 dose escalation. So how do we measure drug toxicity? So hopefully you'll be aware of the NCI, National Cancer Institute, common toxicity criteria for adverse events. So this defines all adverse events according to organ and symptom categories, and they're graded between 1 to 5, 1 being mild, 2 being moderate, 3 being severe, 4 being life-threatening, and 5 death. So this is a international kind of gold standard way for us to assess drug toxicity. So when you're doing clinical trials, be it phase 1, phase 2, phase 3, wherever you're doing it, if you're in the UK, you're in India, you're in America, you're in Japan, every patient is being assessed according to the same toxicity criteria. And I've just listed here, so this is the NCI CTCAE version 4, okay? And I've actually just given an example here of how rash is defined, because there are actually two ways of defining rash, okay? The top looks at the CTCAE criteria for maculopapular rash, and the one below is the CTCAE criteria for acneiform rash. So have a look at this, because I think it's really important for you to be able to understand what toxicities are, what the grades are, how they're defined, because this is how we define this. I mean, often in standard clinical practice, irrespective of being on a trial, but even more so in the context of a clinical trial where this type of definition is absolutely critical. So, a lot of what we do in phase 1 trials is about understanding what the dose-limiting toxicities, or DLTs, are. So a DLT is a toxicity that is considered unacceptable due to the severity and potentially the irreversibility, and limits further dose escalation. Okay, so the DLTs are defined in advance prior to beginning the trial and are protocol specific, and it's usually defined based on toxicities that you see only in the first cycle, because the toxicities that you use within that first cycle can then help to guide escalation in a more rapid way rather than waiting for multiple cycles. Not to say that you don't use toxicity data in subsequent cycles, you do, but in particular for dose escalation type decisions in the phase 1 trial, the DLTs are often only based on that first cycle. And these are examples of dose-limiting toxicities. So these are common kind of hematological criteria, and these are non-hematological criteria. Often when you have chronic daily dosing, for example, with this type of drug, molecularly targeted drugs like Sotorasib, and often in these types of trial, the kind of historic toxicities of, we usually used to define grade 3 non-hematological or grade 4 hematological toxicities. For chronic daily dosing, often you might find that grade 2 is actually a dose-limiting toxicity, just because if you're having grade 2 diarrhea, for example, for a week, that's a pretty significant impact in terms of, and you're on maximal medical therapy, that's a pretty significant impact in terms of your quality of life. So some trials define certain DLTs, maybe even as a kind of grade 2. So for this particular study, for the Sotorasib study, they've said non-hematological toxicity, I've listed on the left, so grade 4 or greater vomiting or diarrhea, or grade 3 nausea for 3 days or more despite optimal medical support, and any other grade 3 adverse event. So I would say that's perhaps, yeah, I mean, again, I think you see that in many studies now, but I would perhaps also include, a grade 2 for more than 7 days despite maximal medical therapy, either for nausea, vomiting, or diarrhea. And on the right is hematological toxicity, which is very common and, which we've used historically from cytotoxic therapies, and which we still continue to use really for molecularly targeted therapy, even though the impact in terms of hematological toxicity is usually pretty minimal. So what about the trial design? So this trial design combines 2 parts, which is again very common in a phase 1 study. So there's a dose escalation part and there's a dose expansion part. Okay, so on this particular phase 1 study, they actually predefined 4 dose levels. Okay, so 180, 360, 720, and 960. So you can see here that between the first 3 doses, they've done doubling. Okay, and then when they've done the 4th dose level, it's kind of the increment is less. Okay, so the increment has actually only actually about 70%. Okay, so that shows you what I was telling you earlier, that in the earliest doses you actually try and escalate as quickly as possible. As you're getting to a higher dose, the increment between the doses usually reduce. Okay, so what in terms of how they have defined the dose escalation, so they, on the paper, which is which I did forward to, I did ask the organizers to forward to you. There's also a supplement, and there's also you can actually on the New England Journal of Medicine page, you can actually see the protocol as well, although some of it is redacted. So you have to kind of go digging a little bit to try and find a bit further detail, because just in the actual main paper, the actual amount of information is a little bit limited. So they've used what's called a modified continuous reassessment model, or what we call an adaptive trial design. And I'll explain a little bit about what that means in the next slide. And they've defined 2 to 4 patients per cohort in that dose escalation period. And then for dose expansion, they have defined 3 cohorts of patients, one with KRAS G12C non-small cell lung cancer, one KRAS G12C colorectal cancer, and another kind of basket group, which is other tumors that have G12C mutation. And sotorasib is given as once daily in 21-day cycles. So these are common phase 1 trial designs. And for those of you interested, I'd urge you to go to this excellent review, which was written by Lillian Su, who's a phase 1 medical oncologist in Toronto, and her group, which I think really nicely explains a lot of the kind of concepts in terms of different phase 1 trial designs. So the standard design that we have historically used for many decades has been what's called this 3+3 design, which is shown in the kind of top left corner here. And in essence, you use cohorts of 3 patients, and you continue to escalate dose until you see a dose-limiting toxicity, which is defined here in red. And if you see a dose-limiting toxicity, you then add a further 3 patients. Okay, and in essence, if you have reached if you don't have any other patients that have a dose-limiting toxicity, you can escalate. But if you have a cohort of 2 dose-limiting toxicities within 3 to 6 patients, then you've reached what's called the maximal administered dose, and then the dose below is what you call the maximum tolerated dose. Okay. Now, there are other designs to do phase 1 trials. So this is called accelerated titration, which uses certain elements of 3+3. So you, for example, will only use single patient cohorts until you get to a certain toxicity grade. So, for example, you get to a grade 2 toxicity, and then you start to expand the cohort into a bigger number, and then you use almost a kind of modified 3+3. You then have others such as pharmacokinetically guided dose escalation. And then what we increasingly use now is what we call adaptive or model-based design, which is in essence where we use a lot more information in terms of preclinical information. We use a combination of pharmacokinetics, pharmacodynamics, toxicities, and it's a real-time statistical analysis and input to predict the probabilities of certain toxicities from occurring, and using that to be able to decide whether or not to continue to recruit a certain dose level or to increase. Okay, this requires a lot more input from a statistical perspective, but increasingly we are using this method, and I think we're finding that compared to the 3+3 design, that generally speaking, it's got a higher accuracy of being able to define what the maximum tolerated dose is, perhaps in a slightly quicker way. But I'd urge you to go and read this paper, as I said, which really kind of goes through those definitions in a bit more detail. So what are the objectives of phase 1 clinical trials? So, these are very standard. And again, for this particular study, the Sotorasib study, these are pretty clear. So the primary objective is to evaluate the safety and tolerability, to estimate the maximum tolerated dose, and provide a recommended phase 2 dose. And secondary objectives primarily are to assess pharmacokinetics. They should be to assess pharmacodynamics, but also to give an idea of efficacy by determining objective anti-tumor activity. And often for these types of trial, we use RECIST 1.1 criteria. There are other secondary objectives listed here, such as progression-free survival and duration of stable disease. And that gives you a kind of hint that perhaps they were expecting to see good responses from the outset, because these aren't often kind of common secondary objectives that we use within a phase 1 trial. Those are usually kind of objectives that you see in a phase 2. So this is the results of the trial, and this first slide looks at the patient disposition. Okay, so this looks at 129 patients were enrolled in total. So immediately you can see that the number of patients is actually quite large. I think in the our previous speaker had mentioned in a table that the number of patients treated in phase 1 is often less than 30, which again, historically it is. But nowadays, phase 1 trials, in particular, because we have that dose expansion cohort, often include many, many patients, and is kind of encroaching almost on a kind of phase 2 type of design and situation. So 129 patients enrolled, majority of which were non-small cell lung cancer, colorectal cancer, but a variety of other tumor types. Okay. At the time of reporting, data cutoff, 22 remained on treatment, but the majority had discontinued treatment because of progressive disease. And there you also get, of those patients who went on, the split between the individual groups. And again, you can see that the numbers are quite large, even across the smaller dose cohorts, implying that a lot of these were expanded quite significantly, perhaps even in dose escalation. So this just gives a bit more information about the trial population. As I said, the 4 different cohorts, the majority of patients were treated at the higher dose level at the 960, so 85 patients. And you can see here that the median age, the male-female sex percentages, race, primary tumor type for each of the cohorts. So this gives a kind of good snapshot of the cohort of patients that have been treated, and in essence, this is a kind of very typical of a phase 1 clinical trial. So in terms of the safety, no dose-limiting toxic effects were observed. There was, which is interesting because, that shows that even at the highest dose level evaluated, there was no DLTs. No treatment-related adverse events resulted in death. That's an important thing. Probably the death rate on phase 1 clinical trials, if you look at different series, probably about one in every 200 patients. So relatively small, but certain types of drugs are clearly, have higher risk of causing treatment-related death. A total of 73 patients had treatment-related adverse events of any grade. Okay, so these are, so often you'll see, and again, if you look at the tables, which I'll show to you in a minute, that it describes the adverse events, but it's not clear. Sometimes it's not clear what is adverse events related to treatment and what might be adverse events related to the population as a whole having their advanced cancer. Because obviously you've got to think that a lot of the adverse events that we see related to drugs, such as fatigue, diarrhea, nausea, might occur in this patient population anyway. A total of 15 patients, so 11% reported grade 3 of grade 4 treatment-related adverse events. And then the grade 3 treatment-related adverse events were a mix of transaminitis, gastrointestinal toxicities such as diarrhea. And if you actually look at the tables that they have presented, as I said, they actually, in the main paper, they only report the adverse events of any cause that occurred during treatment in more than 10% of patients. So that's not particularly helpful. And I thought that this was not presented so clearly. Ideally, you should be presenting what's called treatment emergent adverse events. So this is a phase 1 trial that we did of a PARP tankerase inhibitor. And, here we've defined, the treatment-related adverse events across, these dose cohorts. And this, I think, is a better way to present it, because you're clear then as to what the investigator decided was the actual cause of the side effect, rather than just reporting every adverse event. And in fact, you can get that information if you go onto the supplemental paper. So this is just the first page of this, because in fact, it's presented in such a way that there are 18 pages of treatment emergent adverse events. So not very clear or concise, but this actually just gives you the kind of top, 10, 15 adverse events that they thought were treatment related. Okay. And again, so these are diarrhea, fatigue, nausea, so gastrointestinal type toxicities, things like dyspnea and cough. Again, you think, well, could that just be related because you've got a non-small cell lung cancer population? But then you start to see things like transaminitis, headache, anemia, which potentially are drug related. Okay. So, however, I think you can say overall that the safety profile of the drug looks very good, and in particular, the fact that there were no dose-limiting toxicities kind of goes along with that. So next we come to pharmacokinetics, and again, in the main paper, there is very little reported, so you have to go to the supplemental data. Okay, so we should see a more kind of detailed pharmacokinetic assessment. So there's a kind of few sentences in the main text saying that the half-life of the drug mean half-life was 5.5 hours, and you just get a single PK graph, which is usually not enough within a phase I clinical trial. So actually, this just reports the 960 milligram cohort. So these are very kind of common graphs that we see. So these are concentration time graphs. But what we can't see here is what is the data across multiple cohorts, which is ideally what we want to see. However, what they have put in here is the dose, is this red line here, which is based on the preclinical modeling, what's called the IC90, so the inhibitory concentration 90% in a 2-hour phospho-ERK assay, which is the pharmacodynamic biomarker for KRAS inhibitors. And so you can see here that this is the dose level around which anything higher than that, you would expect to see significant pharmacodynamic effect, and you should see significant treatment response. Okay, and you can see here that with this kind of PK curve at the level that they ultimately will recommend for further evaluation, you can clearly see that the levels are much higher than that. So ideally, we should see the pharmacodynamics of this particular agent within these patients, but unfortunately, we have no pharmacodynamic data at all, which is a big flaw in this study. This slide really just goes through the kind of main sampling strategies that we employ for understanding pharmacokinetics and pharmacodynamics, and being able to understand the PK-PD interaction is absolutely critical. Okay, and referring back to, as I said, that preclinical data. So, from an oral drug perspective, we need to also understand what we call ADME, absorption, distribution, metabolism, and elimination. And we need to understand, as I said, the pharmacodynamic effect. So what is the kind of the target effect? Are you seeing downstream effects that you would anticipate based on the preclinical data? And this is just a study that I was involved with a few years ago of a first-in-class PI3 kinase inhibitor called pictillisib. And here you can see a number of, on this particular pharmacokinetic figure, we've got a number of different graphs here. What's missing from the sotorasib figure, this is ideally what we want to see. So there was multiple dose levels explored in this particular clinical trial, but you can see there's a kind of proportional effect in terms of as the dose goes up, you increase the concentration both from a Cmax, so that's the maximum concentration, and what's called AUC, area under the curve, which gives an idea of total exposure. All right, so you can see here that this type of more detailed pharmacokinetic analysis is really important, and then to link that back to the pharmacodynamics. Okay, so for this particular PI3 kinase inhibitor, we used inhibition of phospho-AKT in platelet-rich plasma. And you can see here that as we increased the dose of pictillisib, that the amount of phospho-AKT inhibition increased. And you can see here the kind of time effects also in terms of the dosing concentration effects as well related to time. So I think for the sotorasib data, we don't really have this kind of detailed PK-PD interaction. But I think from what they will say is that, well, the kind of efficacy data speaks for itself. So this is the efficacy of sotorasib in all of the tumor types listed. And you can see here that for non-small cell lung cancer, it's a nearly 20% response rate, but different in colorectal cancer and other tumors where the response rate was only single figures. Stable disease in about just over half of patients in both the non-small cell lung cancer and colorectal cohorts. Okay, so objective total response rate, 32% in non-small cell lung cancer, 7% in colorectal, and 14% in other tumor types. And so these are waterfall plots. So on the left-hand side, it's non-small cell lung cancer. On the right-hand side, it's colorectal. And you can see these waterfall plots showing, maximal tumor reductions from baseline at the top here. And you can see clearly there's a difference between the non-small cell lung cancer and colorectal groups. And again, these are quite nice, even in the context of a phase 1 clinical trial. We see them more commonly in phase 2, but when you have large numbers of patients, I think it's actually quite helpful and gives you an early idea of the efficacy. I'm not so keen on these progression-free survival curves. Again, these are non-randomized, so you can't really have an idea of really the context here, but for what it's worth, they have given the median progression-free survivals in these Kaplan-Meier curves for the non-small cell lung cancer group, so that's 6.3 months, and for the colorectal group, it's 4 months. And then, excuse me, in terms of the discussion, so whenever you're doing a phase 1, reading a phase 1 paper or doing a phase 1 trial, the discussion really should provide some clarity about the final dose recommendation and the evidence for its selection. And also then you should give some suggestions as to how you subsequently plan to use the drug, what subsequent follow-on studies are being considered. In the discussion, they actually talk a little bit about what I mentioned before about using the pharmacodynamic cutoff in the preclinical tumor models, and saying that the observed mean exposure to sotorasib at a dose of 960 markedly exceeds the same threshold for approximately 24 hours, and this is therefore predicted to achieve near total occupancy and inhibition of KRAS G12C over the entire dosing interval. So on that basis, that's how they have in part justified the decision to proceed with 960 milligrams and to use that for later confirmatory trials. So going back to our pharmacological audit trial, did we define the target population for this study? We did, because it was patients with specifically only KRAS G12C mutations. Okay. Did we do the pharmacokinetics? In terms of what's published here, there's a little bit, but not a huge amount. There's a little bit on PK. The PD, I mean, I put a question mark here, but in fact, the amount of pharmacodynamic data here is actually very, very minimal. It does demonstrate response, and so you can see markers of clear response. If you look at the protocol in terms of understanding mechanisms of resistance to these class of drugs, it is described in the protocol, but it's not presented here. And so subsequent thoughts in terms of how you might overcome that drug resistance are not really discussed or defined. However, subsequent follow-on studies have occurred. So this is the kind of phase 2 study, which actually then led to the FDA approval of sotorasib for lung cancer. And, even the understanding around, acquired resistance to KRAS G12C inhibition is now, we now have greater understanding of that based on some of those studies. So with that, I'll conclude. So thank you very much for your attention. I hope that's been helpful for you, and happy to take any questions.